Yes, sir, I have started.
Yeah, start the recording. No?
I think can non-presenters mute their mic?
Yeah.
So, yeah, good evening, everyone. On behalf of NNF Karnataka, again, we would like to give a warm welcome for our today's speaker, Mr. Kriswen Liao. I hope I pronounced his name appropriately. And we have our speaker, Dr. Sushanth and Dr. Ramakrishnan. So today we'll be discussing on most commonly used equipment in an ICU, that is the syringe pump and infusion pump, parameters about central nursing station, connectivity, clouding, and how to digitalize this so that we have very less medication errors, which is the most common thing what we see in our day-to-day practice. Even after, in spite of having a very good training for the nursing staff, still medication error is quite common, and how to minimize this with modern day technology. And then we have monitors with 3 paramonitors, 5 and 7 paramonitors, low cost versus high cost, touch panel versus rotating hub, inbuilt in the warmer versus as an add-on accessory to the warmer, transcutaneous blood gas, significance of parameters, connectivity of central nursing station, clouding and digitalization. So we'll be talking on illuminator, what we call as cold light as well. So today it's going to be very interesting about the utility and advantages, the cost, and how to do the clouding, digitalization, and connecting all the things, and how to look into your mobile and see all the parameters in one single screen panel. So on behalf of NNF Karnataka, a warm welcome to Mr. Kriswen Liao. Thank you for accepting our request and being part of our webinar series, which we have been doing for the last 3 months on how to set up an NICU. Thank you very much for accepting our request. Followed by his talk, we have Dr. Sushanth. He's the Vice President and Wellness Program Fitterfly. And then we have Dr. Ramakrishnan, who is a lead consultant neonatologist at MKS Hospital, Salem. And today's session will be moderated by myself and Dr. Dinakar Prithviraj sir. And then we have today's panelists, Dr. Suresh, Dr. Kishore Kumar sir, and Mr. Murugan. So now I request Mr. Kriswen Liao to start the session, and we request you to give a brief introduction about yourself, so that our audience know you in person and in detail, and then please start the session. Over to you, Mr. Kriswen.
Yes, I'm here.
You can load the slides and start the session.
Okay.
Dr. Prashant, by the time Chris will start, my name is Abid. So a little bit, I just wanted to, share my experience. 20 years back, I start my career. And when we, I start with the syringe infusion pump. So it was, very simple. Just load the syringe and start giving the drug. There was no, like cloud. There was no, we was not putting the name of the drug, and all errors was coming. Now the technology has changed, and thanks to Chris, he's going to take us through, new technology, what is happening, how we can, overcome those errors. So over to you, Chris.
Yes. So now I can start. Hello?
Yeah, Chris.
Yeah. So now can I start?
Please start the session, Chris.
Okay.
You have to go to your presentation, Chris.
So now can you see my screen here?
There's a lot of audio feedback, so I request everyone else to mute their mics.
真没有了。哎，是啊是啊，什么情况？怎么又没声音了？
网卡了。
什么鬼啊？
他 mute 掉了自己，是不是？他 mute 掉了自己。
哎，什么鬼？
所有人都 mute 掉了，所以他们就没有声音了，就听你讲了，是这个意思，懂吗？
是吗？
For the benefit of time, can we swap the presentation? If Chris is not ready, maybe we can go in for the next one.
Yeah, it's ready now.
It's ready?
Yeah, just because of some network issue. Maybe.
Okay.
Okay.
So you're fine. You're able to. You want some more time, or should we start with the second session?
Now we can start immediately.
Okay, please share your screen.
Yeah. Please share your.
So now everybody can see my screen.
Not yet.
Not yet. Usually it takes around 5 to 6 seconds. Microsoft Teams. For
Probably future session, the organizer should collect the PPT so that, worst case scenario, at least they can run it through and the presentation can be done by the others.
Anmiti, do you have presentation of Chris?
Okay. Just for 1 minute. Let me share my presentation once again.
Chris, you were able to share it earlier. I mean, I think your camera's turned off.
Oh yeah, we can see now. Yes.
Yeah, okay. Yeah.
Yes. Over to you, Chris.
Okay.
Chris, I request you to give your brief introduction and then start the session. That would be great.
Okay, fine. Hello, doctors. This is Chris from Coleman Medical. Okay, here is my big pleasure to introduce myself and our company to yours. As a medical equipment supplier from China, we have 4 years back cooperation with GE and GenWorks since from 2016. So today we are going to talk about some syringe and infusion pumps. For our company, we are basically start from 2002 up to now, over the 80 years experience. And for myself, mostly actually, I'm staying in India. And since from 2013, every year I have 8 to 10 months stay in India. So almost now up to 8 years already staying in India, and every year 8 to 10 months in India. So I'm Chinese India. So today, let's going to see all syringe pumps and the infusion pumps. Okay, let's see the syringe pumps first. For all syringe pumps, recently we have some of the new technology for the single channel and the 2-channel syringe workstation. And we have one more 4-channel syringe workstation also. Let's going to see. Another one is our infusion pumps. One by one, let's go to see. For the syringe pumps, from clinical production introduction and advanced features we are going to introduce. Let's go into see. For syringe pumps, single and dual channel, and one more, it is stackable. One means there are syringe workstations. There are two major types of syringe pumps. For the single channel and dual channel, it's most for the general ward, and some of the ICU is enough. But for the intensive ICU and the operating theater rooms, maybe we need stackable infusion workstation up to 6 channel, 4 channel, or 8 channel that we can also supply. So applications, the single for like single and dual channel, just we introduced it. For general ward, small surgical, then basically it is enough for the requirement. But for the operating theater rooms and the ICU, we mostly need the syringe workstations. So during the surgery time, different drugs and more kinds of drugs may need in the NSU and the operating theater rooms. So that time, syringe workstation is must. I think especially in big surgical, it should be needed this. So for the production introductions, let's going to have a view of this product. So firstly, let's go to see the overview. It is a 4.3 touch screen. Maybe 4.3 screen, it is a normal screen, but 4.3 in the syringe pump is big screen. So for us, it's very easy to have a view and very easy to see the parameter, also very easy to operations. So based on these screens, and we can see it is the operation is become much more convenient for us. And for the outside design, it is very easy to fix the syringe and very easy to move it. So convenient for the operations. So let's go to see the backside. Backside, it has different port, such as the multifunction port. Multifunction port to connect the nurse workstations, and the USB port for software upgrade, and the network port for connect the CMS. And let's see another one. Okay. Yeah. Another, it is the dual channels. Dual channel infusion workstations, it is much more bigger. To compare with the single channel, it is 4.3 touch screen. Dual channel, it has 6.2 TFT touch screen. And in the touch screen, we can see we have a overview for the 2 channel parameter display. And you can set up different parameter boards in the single screen. So for the operations also become much easier. And the size, it is compatible and very easy to movement. But one hand, you can handle was. And it is just 1.1 kg only. So let's go to see the advanced features. So what kind of syringe pumps is needed in the clinic? From our thinking, we are thought number one should be safety. And second one, it is accurate. And more like functions and humanities and like operations details, we also need much more. So first, we're going to have a look for the safety guarantee. For all syringe pumps, normal operations and increased pressure and auxiliary alarm and pressure release. For different stages, different steps, we have different protection. Number one, it is due to we have a large display. So every parameter, it is clearly and big font display on the screens. So it's very easy to have a view of the situation syringe. And number two, we have the setup for different pressure limit. For example, the maximum limiter, it is 580 mHg. So during, if the syringe up to 400, they have different alarm. Yellow alarm, it is the first level. And the maximum level, it will become red color, and it also has a alarm system to send a different voice and send the message to, if you have connected the nurse station or CMS, it can also send the message to nurse station and the CMS. So if during the surgery something stopped the bonus, so they are syringe will automatically release the pressures to protect the patient. For example, once the pressure up to 500 or 580, the machine will automatically release the pressure and maintain the blood is open. So this is the double guarantee for the patient. So we're going to see the next one. So accuracy also is very, very important for the syringe pumps. Anyway, it is this is a machine to send their drugs to the patient. So to maintain the accuracy is very, very important. So for us, how to guarantee the accuracy? Number one, we have the 3 CPU in the single machine. For 3 CPU, it has different functions. Different function can maintain different steps. So it will never happen overworks for the for the CPU. And even one CPU or 2 CPU, it is damaging or stop working, it doesn't matter. Another CPU will continue working, and another CPU will automatically hand over all the machine functions. So during the normal time, 3 CPU, different CPU will maintain different steps. We guarantee different steps to share the works, to make the work become more efficient. Once one CPU happens some issue, or 2 CPU happens some issue, another CPU, even it is enough working for 40 steps. And let's see another pictures. High performance motors. Let's see these pictures. For the black waveform, it is for all syringe pumps motors. Let's see, it's very, very stable. To guarantee the syringe, it is always during the stable situations. And compare with normal syringe, it will become up and down, up and down. So compare with normal syringe pumps, or syringe pump, no matter one speed or the pressure, it will always become what kind of the parameter you set up. It is always make sure what kind of the parameter the output. So this is the machine to guarantee the stable and accuracy injection and the syringe pump. And one more, some features about this machine. Like this machine, number one, it is forwardable display. For different overview, you can adjust the display. So it's much more convenient to use it. And for the display, you can also set up the different font, such as for the long distance, you can set up the large font. Large screen enables a large font display. It is more clear and more identified. Also easy for operations. In a single screen, you can operate in 2-channel pump. And also you can set up in one display. And the faster management.
After you're done with this, and after I'm done with this, do you want to have a video?
I see.
after this and this.
Yeah. So this is the overview once again, and next it is dual channels and continuous injection and dual channel design. So this is another we can see advantages. So for the dual channel injections, for example, if a single channel is not enough, because one syringe maximum it is up to 6 ml. For example, for one patient, we need 100 or 90 ml, so we can use a dual channel syringe. So automatically they can continuous injections. So one finished, another one, second one, automatically start and until to finish the fully process of the syringe. So this is the dual channel, and more comprehensive syringe. We are going to introduce the function. What kind of function? Function is about the syringe injection mode. For all syringe pumps, up to now, we have 10 models to supply different demand of syringe. For example, basic one, it is rate time model, and more it is weight model, and for some advanced model TIVA models, it is the recently new technology to supply the comprehensive injection solution to meet the clinical demands. So totally we can supply 10 syringe models in the clinic, and as per different situation and different patient, we can select the different models. So this is our total syringe pump models. In one word, what we can see it is, in the market, what kind of the syringe pump model is there? We all have, and we have some model which normal syringe pump don't has. So our syringe model, it is more most kind of the. So next we're going to see extensive assistant tubes. So for this kind of function, it will help doctors to working efficient, to reduce doctors' works. Number one, it is automatic identification. When the syringe pump is inserted on the pumps, the size will automatically recognized and display on the screen. And the second one, continuous the titration. So the infusion parameter setting can be modified without stopping it. For example, one syringing, it is during syringe time. If you want to set up the parameter, no need to stop anything, just set up and confirm automatic shift to another one. And more extensive drug library. So for all syringe pump, we can providing 2001 drugs. It is the library to keep store the different drug name and to maintain the name for the next and in future use it. In future, once you have already input these drug names, you have no need to put it again. And also we have net models. So during because we know in during the syringe time, maybe some case it will need more than 2 hours, 5 hours, even 10 hours. So during the night time, it is very important that we have specialized nighttime model to protect the patients. So this is some of our more function to saving the doctors working and to help our doctor working become more efficient. So this is a basic or syringe pumps idea. Thank you so much, doctors. This is basic or syringe pumps introduction. Thanks for your listening.
So Dr. Prashant, if we have any questions, we may have to ask now because it's in Korea, it's late. So,
Okay. Yeah.
Yes.
So I request our delegates who are attending, if they have questions, they can unmute and they can ask Chris directly. There's one question which has come now. How accurate is the infusion rates? Like we have in weight, we have a variation of 0.1 to 500 grams variation from machine to machine. How accurate is your infusion pump in terms of infusion rates? Suppose if you put 0.1 ml, does it 100% 0.1 ml per hour only it goes, or is there any fluctuation or variation?
Yeah, our accuracy, it is we have a specification because we have, before this product launched, we have did a lot of tests in the hospital. So finally we supply the specification to get the CT certificate. The specification maintained, it is maintain the accuracy, it is 0.1%, within 0.1%.
Okay, 0.1% variation. Dr. Suresh, our panelist for today, and Dr. Kishore Kumar sir. Sir, would you like to add anything, or would you like to ask specific questions to our speaker?
Sure.
Yes.
Hi, Kriswen.
Hello.
You showed us your syringe pumps and nice big displays. But what about central monitoring? Do you have a central monitoring solution where they can be monitored? A, and B, you said automatic syringe identification. Do you have like a barcode option wherein the drug can also be identified?
Yeah, number one, it is the central monitoring system. Yes, we have such a software solution. It's very easy. We can supply software, and any computers and the nurse working station connected with the software, and then it will become CMS system. And let's see, this machine backside we have the multifunction port and USB port and the network port. Through multifunction port, we can connect with the CMS. So this is the first question. Second one, it is the automatic identify the syringe. We can fix any size because now in the market mostly it is 5 ml, 10 ml, 20 ml, 30 ml, and 15 and 6 ml. This is the most size. All the size once we fix on the syringe, automatically it will identify and display on screen.
No, I understand that. I saw that, but what about drug identification? Because if you see some advanced systems allow you to print out a barcode label identifying the patient and drug, which you can scan using a barcode scanner, and it automatically populates the syringe pump saying what the drug is, what the medication is.
This syringe machine cannot identify what kind of the drug, because we have to confirm the drug. For example, in the machine we can keep 2,000 kinds of the drug in the library, in the machine library. So once we use the drug A, we can see drug A. During use drug A time, we can confirm this machine is using drug A, and the automatic machine will record like this. Machine cannot identify what kind of the drug.
Okay, thank you.
Yeah.
Yeah. Any of our delegates, if they have specific questions regarding the first session, they can unmute and they can ask directly.
Yeah. Chris, when you're putting the pumps on a docking station, do you have an option of Wi-Fi, or it is only wired?
It means we can connect to Wi-Fi, or we should have wire and wireless option to connect the signal. For the single channel and the B channel, we have only wire, means through cable. Okay, and for the workstation, let's go to up. For the workstation, then we can through wireless.
Okay, when it gets onto the docking station, you have a wireless. Otherwise, single and dual channel, you have only a wired one.
Yeah.
Got it. So how many pumps can get into a single station, single central?
Sorry?
The maximum number of pumps into
Maximum
one.
number of pumps to connect the seamless
Yeah.
is 128.
What's the maximum in a dock? Stackable, one stack.
That we said 4, 2, 4, 6, 8.
That is up to 4 numbers.
4, 6, 8.
Okay.
So, Doc, did you hear how much was the maximum number of pumps in one network in a single CMS?
128, I think you said.
128. Okay.
Thanks, Chris. Dr. Kishore?
Hello?
Kishore, sir?
Yes. Hello?
Hello?
Yes.
Can I ask a question, please?
Yeah, please.
Thanks for this beautiful presentation. How much is the battery life if we have to take a child or move a child from A to B position? Does it hold a battery? Can we use it for transport system as well?
Chris is asking about the battery backup of the machine. How long once it is charged, for how many hours it can run, your pumps can run. Can it be used for neonatal transport or other patient transport?
Yes. So for the battery, you can use up to 8 hours. Battery time. Battery using time means.
Thank you. 8 hours is sufficient time. Thank you very much.
Chris, there is one more question. How frequently you need to get the service done for this? Is there any annual maintenance required for this machine, or how frequently we need to check this?
This machine only maintenance it is clean.
Yes, Chris.
Yes. I mean this machine maintenance, it is we just to keep cleaning the machine.
That's it. Okay. One more question which has come. If there is any future update in the software, will this machine have an update option, upgrading of the software?
Yeah. Through the USB port.
Okay. Yeah. I think that's all. We had a question. If anyone else has a question, they can unmute and they can ask. Or else we'll move on to the next topic. Chris, it was a wonderful presentation. I'm sure this is the technology which we are looking forward in infusion pumps, which makes things much easier and less cumbersome. Medications, especially in neonatal ICU, we calculate, and the dose is very minute, and little bit variation in the drug dosage can have a very severe consequence in neonate. So with the latest technology, we're extremely happy that so much new technology which is coming in. Dr. Suresh, you have raised your hands.
Yeah, I'd just like to highlight one more thing about the stackable. In ICU, NICU, any critical care setup, there's always a shortage of plug points and too many wires running around. So the advantage, major advantage of a stackable system is power management also. So just one power socket can supply how many ever syringe and infusion pumps. So for a practical purpose, in terms of wire management, cable management, it also has a lot of value.
I think an ideal situation for each baby, at least we need at least minimum 5 to 7 infusion pumps. depending on how premature the baby is and what all medication it is. On average, if you take 4 to 5 infusion pumps, and as you rightly said, Dr. Suresh, if too many wires are there, there is a risk, risk of a lot of confusion. So this could be if single dock with single wire connecting many infusion pumps has got huge advantage. Anyway, Chris, Ganesh ji, would you like to speak something about Chris and his session? Mr. Ganesh?
Yeah, thanks, Prashant. Thanks, Chris, for a great presentation. And I'm sure you have been able to showcase across the platform, across the portfolio, what kind of solutions you have, and you answered all the questions. Thanks for accepting our invitation and participating in this. I'm sure it's late in Korea. I don't want to keep you holding. So thanks again. And thanks, Abid, for connecting Chris and getting him to support us for this program.
Thank you for this time.
Chris, on behalf of National Dental Forum Karnataka, thank you for in such a short notice you accepted a request. Thank you, Ganesh ji, and thank you, Chris.
My pleasure.
We will move on to the next topic. That is by.
Thank you, Chris.
Yes, thank you.
Krish, yeah,
Yes.
thank you.
Okay, thank you so much.
So now I request Dr. Sushanth Thapa to start his session. Dr. Sushanth?
Hello. Hi, good evening, everyone. I don't know if you are able to see me, hear me.
We can hear you. We can hear you, Dr. Sushanth.
Okay, great. I'll put my presentation up. Hi, guys. I'm Dr. Sushanth. So I've worked with critical care and primarily in digital critical care area for about almost a decade now. Incidentally, I started my career with GE, and then I worked with Philips and Geo as well. And some of the expertise is primarily been in digital therapeutics and how to digitize critical care areas across different verticals. So that's what I've been doing. And now I work with a digital therapeutic startup called FitApply. And we're just trying to scale up this startup with primarily deals with critical care and chronic disease management. So that's my brief introduction. I'll start with so what I've done is because I think there's a mixed bag of people who are really expert in their field, and there are people who are also beginning to learn. So what I've done is the presentation is kind of divided into some very basic stuff about how patient monitoring works, how neonatal monitoring is a part within that patient monitoring. What are the different options when you choose a patient monitor? And then we'll go to digitization as well. What are the components of digitization, and how it all comes together to kind of bind a hospital and then bind multiple hospitals. That's the overall mix. I hope there is something in it for everyone. If you sometimes find it's a little more basic, that was the intention to put a little more basic stuff in there as well. But then I'm sure you'll also find digitization really interesting. Right, so I'll just start my presentation. Let me know when you're able to see my screen.
When was your stint in Philips, and was it in India?
Yes, so I was working in Bangalore and Gurgaon in GE, and in Philips I was working in Mumbai primarily. But I worked with different teams in Philips actually. Not so much in GE, but in Philips I worked in teams across US, Austria, and Netherlands, of course.
Okay, because I was a product of Philips between 97 to 2016, so 20 years of Philips.
So, okay, so I think between us we have covered a lot of time. I was there from 2017 to 2020.
Okay, because that's what I wasn't like.
Yeah, so I think
I joined Hewlett Packard in 97 and I continued in Philips to 2016.
Okay. Awesome. That's so nice. Sometimes a lot of people, I don't know how many people know me here, but sometimes it's a very small community, right, of critical care people.
See, even Ganesh Prasad, we have been hearing, he's a big name in the industry. So,
yeah,
but I've never happened to catch up with him. This is the first opportunity which Dr. Suresh.
Wow. So I think it's a small community, but it's a very tightly knit one as well. So we'll definitely catch up, sir. Are you able to hear me?
We can hear you and see your
Yes,
presentation.
Sushanth. Yeah,
Okay.
Sushanth. Yeah, we can
Perfect.
see your presentation, or we can hear you clearly. Please go ahead.
Great. So you can see the presentation now. Okay, I'll start. So guys, it's a very sometimes if you feel it's a little basic, please forgive me. I just wanted to cover all the bases. That's why. Okay. So let's talk about some very basic fundamental thing about humanity and then in healthcare in general. So when you look at entertainment, even about 20-25 years back, there was 2 channels, and there was Ramayana in the morning, which again happened with us in the lockdown, and then there was news in the evening. That's it. And then the whole thing would kind of stop in the middle. So entertainment was collective. Everybody would sit down around their TVs and then kind of look at the television, right? That everybody has experienced, even if they are like not very young or very old. So everybody has experienced those kind of things. What is happening now is we have moved towards more tailored entertainment, right? So we have Netflix, we have Amazon Prime, and all those things. Things are very tailored, right? So what I want to see, if I want to see a horror movie, I want to see a comedy movie, I specifically go to that genre, and it's available to me. So the entertainment has become very tailored, right? What happened to communication? So I hope most of you who had friends outside India or who had friends outside state even at one point had to book a call and then kind of place that call, and then they'll connect you to somebody, the operator will connect you and then connect a call, right? That everybody is a witness who is more than, I don't know, 20 years old. So now all the information that you have is available to you today, right now at your fingertips. Everything you want to know, what are the most important movies of Devanand, that's there. You want to know who is in space right now, that's there. You want to know how many astronauts are right now circling in the sky, how many flights are up in the sky above your head right now. So that also, the information is very easily available when you look at communication also. What is happening in healthcare? Let's look at healthcare. Okay. I hope you can see this. It's a very important thing. Yeah, we started, with a lot of trial-based medicine. Sorry. Yeah. We started with a lot of trial-based medicine even about 30 years before. There was anesthesia was still growing up, and we didn't have a lot of parameters. Now we have robotic surgeries, and we have tele-ICUs and all of that stuff, right? So we've moved now from just a trial and error to a lot of evidence-based medication. And from where does that evidence come in? It comes from data, right? So 2 things here become very important. One is when the patient comes to your ICU, when he's, whether it's a neonate, whether it's a grown-up adult, once the patient is present in any care area, one important thing is to gather data. Second, that data should be gathered efficiently. And third, the dissemination and the interpretation of that data should be efficient. That's how you create evidence, and that's how you kind of know, okay, this medication works, this doesn't, this protocol works, and this doesn't, right? So the idea is we've moved a lot in communication or in entertainment, but we're still kind of finding our feet when it comes to evidence gathering in healthcare. And that's what I'm going to talk about. What kind of helps us in that evidence gathering? What kind of devices are available to us, and what kind of data can we hope to gather from these? So this is, I think, because I think Avid connected with me, so primarily it is going to be focused on GE. So there are, these patient equity segments that primarily, any company, not just GE, any organization divides their offerings into. You start with very basic stuff where you have some basic parameters, which I'll go into. Then you go into mid equity, where you also add things like a little advanced parameters. You add invasive blood pressures, you add your ETCO2 monitoring, you add transcutaneous monitoring. And then you go into high acuity, where you also add things like adequacy of anesthesia, entropy, and surgical path indices. And you add stuff like EEGs and all those parameters. And then finally, when you come and combine all of these together in any care setting, you get what is known as central monitoring. And once the central monitoring is set up, then you go and connect other things into it. You connect your lab systems into it, you connect your PACS systems into it, and kind of create a much larger, more intelligent system. And nowadays, what we also do is also kind of, because now we are feeling more adventurous about healthcare, we also add a layer of artificial intelligence on top of it, which is the new buzzword in healthcare, right? So that's the overall idea. This is what monitoring today looks like. You start with a very basic monitor, which can just monitor SpO2 and your NIBP, and then go all the way to very advanced parameters, 16 or 20 odd parameters at one point, including what gases are there, what analysis, ABGs, and all those things are present within the monitors. So that's just a quick overview of how we kind of label different monitors across care areas. I just wanted to put this across, not just to represent the monitors, but to represent what kind of offerings they have in terms of features and sizes. So typically, a monitor would have a 10.4 to 12-inch display, which is a transport monitor, as well as a stationary monitor, a bedside monitor. All of them usually will come with a neonatal option, which I'll show you in some of the screenshots. How do you activate those options? There are two things in terms of input values. You can either use a remote, you can either use a touchscreen in some monitors, and in some other monitors, you can use a trim knob, which has been the input keys for some time. Trim knob, you started with dash monitors, if somebody remembers. I remember very correctly because when I was there, we still were looking at solar and dash, and I don't know. I've recently seen a 20-year-old HP monitor, sir. So that's it's still there, I think, but we're moving in a direction where most of the monitors now have digital outputs, and they kind of look at advanced parameters as well as advanced input areas. And then if you want the display to be larger, you can of course hook in more displays. You can add in more modules. I'll quickly also go through a list of what modules can be added. The basic parameters include, of course, ECG, NIBP, SpO2, and to some extent you can add respiratory parameters, and later on you go into EtCO2 and larger parameters as well. All these parameters together combined can give you trends. These trends can last anywhere from 72 to about 170, 180 hours. All of these also have what is known as snapshots, which are essentially event snapshots. Something happens, and then the monitor either takes a snapshot, you can take a snapshot, it keeps it stored in the memory for some time, or it sends the data to a central station where the snapshot is stored, so that it becomes a part of the data, a patient's data overall. A lot of times what we're seeing now is it doesn't matter how much storage space a monitor has, because a lot of institutes, what they're doing is they're also moving towards central monitoring, and the data comes to a central server. It stays at that central server, which I'll talk about later, so that you're able to retrieve that data. What other things that we have kind of also looked at, how the needle is moving, is that this data is getting digitized, which means all of this data stays in a server, gets pulled up through a separate software, and most of the ICU doesn't have a lot of papers to fill, right? So right now, whatever you're filling in terms of your daily assessment sheet, that kind of becomes digital. Again, if it's a transport monitor, it'll usually have a battery inbuilt, which will be about 4 to 5 hours of battery. Typically, that's the case, but there is always the option to swap in batteries for more advanced values. Of course, there are monitors and modules which have inbuilt batteries, which can transport the monitor, transport the patient from one place to another. I hope PDM module is still there with GE. I haven't been in touch for some time, but what I remember is we used to have PDM module which had a battery inbuilt, and all of this data that I just told you about, all of this, right from waveforms in ECG, from numbers, SpO2 numbers, EtCO2 waveforms and numbers, all of this actually can be sent to not just a central server, but also to a mobile server, which means the data is the digitization enables doctor or the caregiver to see all of this data on a mobile phone. So if you're moving around, if the not just patient, if the doctor is ambulatory, he's moving around, he's on a vacation, so you can always again kind of get back to him and ruin his vacation and tell him, okay, I need to take care of this patient. I think that sometimes happens for good reason, but that's something that is a part of critical care as well, very important. I'll just quickly, these are just components. I don't want to go into details of what all this does, but I'll just quickly, if somebody wants to identify the components on a screen, these are what the components are. There is usually a trim knob that we're talking about. If the screen is touchscreen, then all of this area becomes touchscreen. You can actually touch the screen at various parameters and kind of also manage them from there. There will be things where the parameters can also be managed out from the buttons that are available. There's usually a very big alarm light. Philips monitor has smaller alarm lights. GE monitors have bigger alarm lights. I'm not too sure about others. I think Mindray also has a very pretty looking monitor. So all of them have kind of different protocols in terms of visuals, but the basic structure remains the same. You need to have a very large alarm light which flashes. There is a command board keys which are present for you to change your parameters. And then there are modules slots available and a recording slot available. These module slots can be fixed or can be interchangeable. Most of the monitors come with fixed module slots as well, with fixed parameters. What those parameters are, I'll show you a little bit in more detail. There are battery slots, and then there is a module slot where you can put a module of your choice. You want to do an ETSO2 for some patient, you want to look at EEG module for some patients. So all of those slots can be fitted into different slots that are available in different monitors. So again, this is I'm trying to make it as agnostic from one organization as possible, but of course, I mean, most of this stuff is, I mean, courtesy GE. This is an important slide only because what I wanted to show you here were the ports. So nowadays, it's what you have to do is sometimes it's important to identify whether the monitors are digitally enabled also or not. In that case, you just have to ask or look for network ports within the monitor. And once the network ports are available, there are a lot of options to get the data out and kind of put the patient monitor on network. Why is this important? Again, is because the communication becomes easy and your road to or path to digitalization is that much more easier. Right. So I'll not go into details of what other parameters are there, but important thing is to remember that there should be network ports so that you can always hook up your monitor to a network. This is what I was talking about, in terms of overall control center keyboard. So usually there is a keyboard present in most of these monitors which have parameters at one end. This is monitor setup at another end. And then if you want to reset your NIBPs, you want to silence your alarms, you want to go to the home page, you want to zero your IBP. So all of those options are available right at the monitor. So it becomes a single touch thing. Essentially, you don't have to go into the monitor and fidget with options. It's the same reason why still, even the luxury cars come up with a trim knob to increase and decrease volume. All of the components are not on touchscreen because sometimes you need some kind of tactile feedback to look at and operate machines. So again, it's an important component. A lot of monitors which have complete touchscreen also come with a separate remote which you can actually use, which has buttons, which has all these functions. With GE specifically, I think I've always liked GE for their need for adding a lot of different technologies and condensing them together, right from Masimo's Nellcore SPO2 to Dynamap. So they still kind of, I think, keep increasing their portfolio in terms of what technologies are available within the system. So right from IBP to SPO2, so all the major technologies, including not just their own GE SPO2, but people like Massimo and Nellcore also very happily work with GE and kind of provide them with their technologies. So there's no dearth of parameters or in terms of efficacy and clinical excellence that GE brings to the table. This is a basic, again, module with the IBP, temperature, SPO2, ECG, and of course there is an IBP as well. So those parameters are available in this monitor, and then you can add more modules. In terms of general measurement capabilities, I think I've already covered, but usually you can have from 1 to about 2 channels of invasive blood pressures. Similarly, through a Y cable, you can have 2 channels of temperature measurement. So you can have a core and an ambient temperature that you can measure, or a skin temperature you can measure. There are recorders present for immediate events within the system. Impedance respiration is something which is derived through ECG leads. Again, there is, as the monitor, display size increases from, let's say, 12.4 to 15 to 21, whatever it is, your capability to display waveforms also increases. And it is true for any system. A smaller iPad and a bigger iPad, you will be able to see much more data and much more information on larger screens. And those options are available within different monitors. I've just taken some representative monitors for GE here, but essentially you can also kind of look at larger displays, and they can be hooked to larger displays. And now we're seeing a lot of trend where once the data is digital, monitors are hooked up to larger displays. what it does is displays are getting cheaper. So it's not very cost sensitive to put up a display. And second, it also helps patient. At the end of the day, what we're trying to do in critical care scenarios is we're trying to put patient and their attendants at ease. That's the first thing that we're trying to do. Second thing that we're trying to do is improve outcomes. I think as a doctor or as a person who works with healthcare in general, that's the bottom line of it. What we're trying to do is put our customers and patients at ease. And secondly, we're trying to improve outcomes through these machines and through the technology that we're bringing into the hospitals. So I think when you hook up these monitors to larger displays, that really helps the patient also to see, okay, things are going right or things are going wrong. So it becomes a little more transparent in terms of process. Most of these monitors have neonatal modes, so there are different modes, right from step down units to let's say neuro ICU or a pediatric ICU to a cardiac care unit to a pediatric unit or an emergency unit. There is also neonatal modes where your values and essentially the limits of parameters will change to match neonatal parameter limits, and rest of the things remain the same. And you can of course adjust limits according to your choice as well. But essentially, it will give you a different kind of layout when you shift it to neonatal mode. So you can use, then you can of course use screen setup to also kind of configure different leads and different waveforms accordingly. So I just wanted to put it out there so that this is in the interest of full disclosure. This is what I was talking about. So essentially a fixed module would look like this. It will have two, for example, invasive ports, two temperature ports. There'll be an SpO2 port, which can be a Massimo, Nellcore, or some other technology as well, depending on the kind of configuration you're looking for. There's an ECG port, and then there is an NIBP port as well. Colors are also similar for different organizations. Personally, again, I think GE has better quality ports and monitors, and that's pure. Is somebody asking me a question?
Yeah.
Can I go ahead?
Can I ask a question? Yeah.
Sure.
Yeah. Please go ahead.
So Philips uses something called a Fourier resist suppression technology, and Massimo uses something called the SET technology and all that. Like, what is the technology used in GE SpO2?
So, Sushanth, you are there, Sushanth?
Hello.
Yeah, Sushanth, go ahead.
I think I disconnected. Can you repeat that, please?
Okay. So Philips uses the SpO2 technology, which is called a Fourier resist suppression technology, and of course we all know Massimo uses SCT SET technology.
Yeah.
What technology does GE use?
So I think I can let other people also take this, but I'll take this. So GE SpO2 is a proprietary technology again. Essentially, if you look at Massimo, what Massimo does is it has more, I would say, so the interest or the focus is on the movement part of it as well. For Philips and GE, for both of them, the focus is more on the accuracy part of it as well. So that's the difference. And their ranges usually, what you see is the overall fluctuation in terms of SpO2 ranges would be much less with GE and SpO2 both. It's very difficult to choose, accuracy. It also depends on what kind of protocols you have and what kind of patients you have in general. But I would say there's very less to choose between these technologies. But Massimo, the focus also is on movement, which is, I think, some people prefer that for that reason. But there are no specific, algorithmic differences in terms of how these technologies work with GE and Philips. These are just proprietary technologies. That's what it is.
Yeah. I think Dr. Sushanth?
Yeah.
You are done with the presentation, right?
Yeah, I have just 2-3 slides on digitalization remaining.
Yeah, please go ahead.
Okay. All right. You're able to see my screen?
Yeah, I think we lost you the last slide because the audio dropped out.
Okay, I think there was some issue. But you're able to see my screen right now, yeah?
Yes, yes.
Yeah.
Perfect. So I wanted to go through the parameters, but I'll just show you. I think let's look at this, and I'll just quickly show you what digitization essentially is. I think this is an important point for any doctor. This is even when the baby is gasping and the saturation sometimes is good. So it's very important to look at clinical judgment and then look at monitor, and not the other way around. And this is something that I kind of focus on all my presentations at. At the end of the day, clinical knowledge is superior than whatever monitor is going to. They can amplify and they can support you, but this is something that always needs to be remembered. This is something that I'll just put out there to tell you what is happening in terms of continuum of care. So what happens is typically a patient moves from let's say an emergency room to an ICU or a preoperative, intraoperative, postoperative setup, back to the ICU and then to the ward, right? So the idea is to maintain data across this continuum, and that happens through different channels. For example, one thing I think Chris also pointed out was that infusion pumps now are coming in with a lot of connectivity options. And again, you don't need a central station to be fair for any of those connectivity options. They directly can send the data to a central server, and that central server is intelligent enough, through G centricity, for example. It's pretty intelligent that this data can be stored in context, and then can be presented in context later on as well. So, for example, right from infusion rates to drugs and interactions, along with patient condition and care area. So all of these things actually get combined at the central server level. So once the patient moves, the workflows of course change from ICU to ward to operation theaters. Anesthesia comes in ICU cases. The parameters will change, and in ward you'll have a more relaxation in terms of what parameters you are kind of addressing. But we'll also move towards things like early warning scores and modified early warning scores and stuff like that. So I've not gone into parameters. I'll just show you a basic idea of what it looks like. So all of the data is essentially stored and shown here on a system. This is an actual picture. So there's a patient monitor hooked up. There's a syringe pump or a rack. And again, a lot of people now, of course, prefer syringe pump racks. So there are about options of 4, 6, and 8 syringe pumps that you can stack within that time. And of course, like somebody pointed out earlier, very important in terms of power management, very important in terms of getting the data right as well. And their connectivity is very good. So one rack, you just need one cable. Sorry, is there a question? I'm not able to hear clearly.
I think that's someone who's unmuted there.
Okay.
Please go ahead.
And then, of course, Abid's favorite ventilators are also there, and all of this data kind of gets digitized, and you don't have paper records anymore. You kind of, through Centricity or ISA or different digital modules, you can actually see the data on a system, and that's where all the data manipulation can also be done here on the system and can be sent to different sources. This is what I wanted to show you. So within a typical ICU setup, there is a central monitoring. There is devices which are hooked up to a central thing like Centricity and through an aware gateway or different kind of gateways that kind of join these devices together. Once this is connected to a hospital system, hospital information like hospital information system, labs, pharma information system. Once you connect it with that, this becomes one integrable system across hospital infrastructure. When you take this system and move it across different areas, it goes to a command center. So for example, now I have 5, 7, 10 hospitals sending me this data. Then it can become a command center. So the command center essentially will have every patient data across these hospitals. And once I take this command center and also apply smaller devices to it, then the intensivist who is on the move can also get this data through an internet connection. It doesn't need a hospital infrastructure. So hospital infrastructure remains till here. This is all within a hospital network. Once it goes outside the hospital network, you have internet access either through a command center or on an intensivist, so that the decisions can be made faster. So that is the overall workflow of how a digital critical care solution works. Components somehow look like this. So you can see your PACS images of a patient. You can see the audio video of a patient, their parameters, a dashboard. This is a hospital dashboard, and this is an individual patient dashboard. So all of this data is available to at one particular time, right? So right from your work list, what kind of patients are available. So all of that data is essentially available within the system. What I want to do is finally leave you with this. This is a typical ICU paper template. I don't know if you're able to read any of this, but yeah. So it will have ventilatory parameters, vitals. There is some information in terms of how the patient is and their demographics and their input-output values. Okay, what treatment is there is here as well. You have nursing care notes. You have some reports. You have some care bundles. All of that information is there. There's scores also, including VAP and GCS and all of that. Okay, and this is a typical sheet. This is what it looks like when it's filled. So what I try to do is sometimes, let's say I want to write a paper now. And I go and try and read this sheet. It reads something like this. Now I don't know what language this is, but doctors and I don't know nurses, but doctors are notorious for great handwriting, and this is what it looks like essentially. And if I want to, kind of now get information out of this, it's kind of difficult, right? So the idea is that how do I get answers out of this, right? If I have this as a bundle, a full paper bundle of patient records, I can't get answers out of this. Imagine this is one patient, and then I'm looking at a 50 patient cross-sectional data. It becomes almost impossible for me to go and search for this data and make sense of it, right? So the idea is to keep all this information, make it available, digitize it, and so that it can look something like this. Your vitals are available to you across time durations. Your waveforms are available to you. Your input-output values are available. Your monitoring parameters are available. Your ventilatory parameters are available in one screen. And if you want to look at, vital signs graph specifically, you want to look at some lines, you want to look at any assessments and treatments, you want to look at what labs have sent in. So all the information becomes available at one particular screen. And this is available across patients, across different ICUs, across different care areas. Not just, neonatal areas, but also, other centers. So you can compare, mix and match, and do a lot of other things. And this essentially is what brings me back to what I started with, that it is important to get the data, make sense of data, so that we move from trial-based medication to evidence-based medication, right? And this is what I leave you with. I think to summarize, I think we started with some basic parameters of how patient monitoring works. What are some of the basic parameters that we can measure, and how do we digitize, and what the digital workflows look like. Of course, I mean, all of these topics have their own. You can stretch it up to 2-3 hours, in terms of how you can kind of debate and talk about them. But this is what I had. Any questions? I'll be happy to take them. Thank you so much, and thank you, Abid. Thank you, Ganesh, for your time. It was really nice. Thank you so much.
Questions we'll take after the next talk.
Sure.
So thank you, Dr. Sushanth. Thank you very much. I'm sure there are a lot of questions which are coming up now. So we will take up after the next session. So now I request Dr. Ramakrishnan to start the session. After that, we will have our panelists, 3 panelists, Mr. Murugan, Dr. Suresh, and Dr. Kishore sir. They will give their perspective, and then we'll take up the questions. Over to you, Dr. Ramakrishnan.
Thank you, sir. Can you hear me now? Can you hear me?
Very clear. Very clear. Yes.
Okay, thank you. And can you see my screen?
Not as yet.
Not yet? Okay, one second. Can you see the screen now?
Yes, it's coming up. Yeah.
Okay. So first of all, I would like to thank the organizing team for having given me this opportunity to speak in front of you. It's a great pleasure indeed. And one of the panelists, Dr. Suresh Vishwanathan, he is the boss of our hospital. He's the MD of the hospital. And although he's a doctor, he is very tech savvy. And I would like to say that without his help, whatever we have done wouldn't have been possible. So with this note and with the support of the well-wishers like the organizing team, I'm happy to kickstart my presentation. Now, my talk for today is on, I think there will be an overlap of previous speakers and what I'm going to talk. But One thing mine will be slightly different is because I'm a clinician and I'm a practicing neonatologist. I would like to show a bit more of practical issues. I hope there are a few doctors, neonatologists in this room, and I think it would be useful for them if I show the practical aspects of it. Okay, so the next, so my topic is on syringe and infusion pumps. The parameters, connectivity via central nursing station, clouding, digital network, all those things. And then I've been asked to talk about transillumination, which is the cold lamp, and also on transcutaneous CO2 monitor. So I'll see how much I could cover, as much as possible. Okay, now to begin with, this is a very sick, for those who have not seen, many of you would have seen a very sick baby in the neonatal intensive care. And you can see that this baby has multiple devices connected. There is an SLE 6000 ventilator which is running, and this baby also has a nitric oxide connected to this. And you can see that there is a brain function monitoring that is being connected to this baby. This baby is quite sick, requiring lots of support, and this dock with so many infusion pumps and the non-invasive cardiac monitor on the cooling machine. So this is how typically a neonatal intensive care looks like. And what happens is, in the past, we used to take data from all these things by hand, which is quite cumbersome and complicated. So the current concept is trying to digitize everything, and that's what the previous speakers have highlighted. I'm going to focus on certain areas of my topic today. So syringe, infusion pumps, and prescriptions. So what I am going to do is, excuse me for a second, I'll just switch off the fan so that you can hear clearly. Okay, so with the syringe, infusion pumps, and prescriptions, I'm going to take you through a video which will step by step, for clinicians, it'll highlight how easy it is to use and how easy it is to get transformed from paperwork to digital work. Now, traditionally, this is what we used to do, as Sushanth pointed out before. It's difficult to understand what we write, and this is how it used to be, and all paperwork and all those things. But now, this is the dashboard where we come to the ward management. This is the landing page of the software that we have created, and this will take to the bed management. And imagine, a bed number 18 is free, and I'm trying to enter the baby's medical records number. So basically, I'm trying to put a prescription. I'm going to admit this baby and to generate a prescription and connect the syringe pump for this baby. That's what I'm trying to do. So once I put in the basic numbers and then put in the basic details, so I'm calling this baby, as baby of Mrs. Rose. This is just a test. This is not a real baby. And then I register the baby and then put in the basic details like the date of birth, the gestation, male, female, right? And I also put in the weight of the baby. And just put in where I want the baby to get admitted, say, for example, in the neonatal intensive care, and then in bed number 3, in room number 3 and bed number 18. So this is the basic information that I fill in for each baby, which a nurse can easily do. And then, once you go to the ward management page, you can see that the baby has been admitted to bed number 18. So this is baby Rose, born yesterday, and you can already see that the monitor, this is the monitor symbol, which is green. Monitor is already connected, but the rest of the equipments are not connected. Now I'm going to work on the prescription, which is shown here. So what happens now, we will see. So instead of writing the prescription by hand, I'm going to enter the prescription electronically in the software. So what will happen is, first I'm going to put 10%, I put the weight of the baby. So I'm going to put the weight of the baby as 3 kilograms. And then the first medicine that I'm going to put is 10% dextrose. And the total volume, I'm taking it in say, assume that I'm taking 500 ml. And then I'm running it at 10 ml power per hour. You can, I'm just doing it for a sample, it's, and then the next medicine that I'm going to put is dopamine. So this baby, the strength of the dopamine is 240 milligrams, and I'm putting it in a 25 ml syringe, and I want that syringe to run at 0.1 ml per hour. So once I do this, the prescription is done. It's waiting for confirmation. That's what the orange color shows. Once I confirm it, it says confirmed. It changes color to blue, and then it goes to the pump queue where it turns red and all those things. So different color coding for different status of the medication. So I'm confirming the dopamine also, and once I confirm, it changes to blue. So what happens is, after typing the prescription, right, now I need the barcode. This is the barcode printer. So this is the printer which develops the barcode, and you can see the prescription, whichever I prescribed, I'm able to get a couple of labels to say that one is a 10% dextrose and the other one is dopamine. So this is to enable safety. So this is 10% dextrose, and on top is the dopamine. This is to ensure that the nurse prepares the correct medicine and then puts the sticker onto the medicine. And if the sticker on the prescription doesn't match, then the pump will not accept it. So these are all to prevent errors. So this is the 10% dextrose and the dopamine label. And what happens is, I'm putting the 10% dextrose label onto the syringe pump. And so once this is done, the nurse places this on the dock, on the syringe pump setup there. Before that, we have to switch on the dock. The top part of the equipment is the dock. This is the brain of this pump set, and this dock communicates with the rest of the individual syringe pumps. So once the dock is on, and the first tray here, it says that the syringe has to be loaded, right? And then what happens is, I'm scanning the barcode. This is the syringe that I'm scanning. And the moment I scan, the prescription that I gave, 10% dextrose, automatically comes in. You don't need to type in. You don't need to type in the pump whatever you want to do. You can. It just takes all the information, and then it says this has been assigned to slot number 1. So this ensures that the correct medicine is loaded onto the correct tray and the correct dosage is going. These are all to minimize the errors. And what happens is, after that, I just look at the display there, and then I confirm it. I read it. I ensure that it is all okay. And the nurse places the syringe of the 10% dextrose there, after ensuring that that's the right thing, right? And then there will be a sticker on the pump also, on the syringe also, saying that it's 10% dextrose, so you can match all those things. And once you close it, you just press start. That's it. So you just accept, and it start to the prescription is executing now. It's going on now. And similar thing for dopamine. You do the same thing. Press the stick the label onto the syringe, and then you can select any pump, and it will assign it to whichever pump you want to. And then the nurse places you're scanning the barcode to ensure that the data is matching, right? And then the nurse places the pump, And once the nurse places the syringe, and once that's placed, you switch on the pump, the syringe pump, and then you will get after the so dopamine should be displayed there. So it will change now. So dopamine has come there. So it confirms that whatever you're prescribed is coming there, and that's the same medicine that you're keeping. And then you confirm it and then start the pump, right? So this is how easy it is, right, to prescribe whatever you want without using paper or pen. And it also displays that baby of rose, 10% dextrose, dopamine, all those things are displayed there. And you can place any number of medications in a similar way. This is a 8, and then what happens is this comes to the central station. So I start. This is the central nursing station, and this is infusing, and this is 10% dextrose here, and it's running at 10 ml an hour, and this is dopamine. So this is running at 0.1 ml per hour. It's infusing now. So that is the central station. So this is how simple it is. I can sit at home, watch how many each baby, how many pumps are connected, what is the rate running, is the nurse currently running it, or have they switched off by mistake. So I can find out everything by sitting at home or in my mobile phone. Can you please mute the mic, please? I'm getting some interference. Okay. So, and then what happens is, this is the central monitor where, for this baby Rose, I haven't connected all of the things. This is just a testing, but you can see the rest of the babies. You are able to see some heart rate monitors and all those things. And on baby Rose, I'm seeing the what you call the infusion details. Now, what do you need to set up this one? So you definitely need a barcode scanner. This is very cheap. In many of the departmental stores have it. So this is not an expensive equipment to buy. And also the pump, we have to ensure that this dock, the top bit is the brain of the pumps. So that is slightly expensive, but that needs to be that should be available so that this communicates with the rest of the pumps. It's difficult to individually control individual pumps without the help of the dock. I think maybe later Dr. Suresh may be able to give some explanation about the importance of the dock and all those things. But and then, so this is our workstation. This is what we daily do. So this is the barcode printer that we need. And the rest of and you need a network cable. Somebody was asking earlier whether it's Wi-Fi or network. Yes, both the facilities are available, but with the Wi-Fi, the problem is there are lots of interruptions, and sometimes the data doesn't come through continuously, whereas with network cable, these problems are all circumvented. So network cable is important. And so this is our workstation, where this is a demo monitor that we use for developing this software and trying to integrate all the machine. This is the SLE 5000, which is in a demo mode now, basically. And then this is the IOMT, the Internet of Medical Things, which from, this basically captures all the data from the SLE 5000 ventilator, and then the data is sent to our computers. So this is how we capture the data, we enter the data. This is our work lab here. Okay, now what I'm going to show next is what happens after we collect the data. Now, so after this data, after the prescription is done, so I can show you different screens. So this is baby Rose, the test, the baby that I showed you. So I prescribed 10% dextrose. This is the nursing chart, which Sushanth was telling. So instead of the handwritten one, I think with this technology, the dextrose 10 ml per hour, this is a total, this is 10 ml per hour, then total 20 ml. So running total every hour it captures. So, and then the dopamine 0.1 ml per hour, 0.1, totally it has run for 3 hours and this is 0.3 ml. So all your input output chart, they automatically get calculated. And so this is, so far in 3 hours, this baby has received 30.3 ml of fluids. So this is how easy it is. And this is another baby. You can see this baby is on morphine, vercuronium, isolate P, vancomycin, and this baby is getting so many infusions on a continuous basis. And the nurse, they don't need to touch their paper or pen. It just automatically comes, and the nurse just have to print the sheet. You can directly view it, or you can print it and file it in the notes. So this is one, and also not only that, you also get the temperature data, you also get the heart rate data, the blood pressure data, and your perfusion index from the monitor, everything, oxygen saturation index. We have created a formula to calculate it from the monitor, which uses the saturation instead of the partial pressure of oxygen, and you get your oxygen saturation index live here. And then this baby was on the high frequency ventilator. You can see that this baby is on HFOV. All the parameters are coming up here. So this is how easy it is. Instead of writing everything, everything comes automatically. And this comes as a numerical data. But you can also make this appear in the form of a chart or a bar diagram or a dot diagram, whatever it is. As far as you get the data, you can present it in n number of ways. So this is how we capture the data, and the nurses have access. And not only this, you also get it in the form of graphs. And you can see that, this heart rate, blood pressure, all those graphical representation is also possible. And you can different types of, you can all set it up in one chart, or it can be displayed in different charts. So this is the graphical representation of the data. So you can see here that the heart rate is displayed on a continuous manner, and you can see the median, the interquartile range, and the range of the heart rate during that 1 hour period. So everything is graphically presentable. And not only this, when the child is going home, you just enter the discharge details, and automatically the discharge summary gets generated, because all the data, they are captured, and all you need to do is to, from the machine, it captures all these details, and the discharge summary is automatically generated. You don't need to sit and type. There is a place that you can type extra details if you want, but most of them are generated automatically. And if you want to generate your annual report, again, at the touch of the button, you can generate an annual report. You can just, like bank statement, you can put a from date and to date, and this will automatically generate an annual report. All charts and graphs, whichever you want, you can set up whatever you want. So this is the ease of digitalizing the data. It's easy to, entering data is also made simple by automation. Capturing data and analyzing data is all becoming easier. So this is how easy it is to work with this. So this is the glimpse, summary of what I wanted to present in this particular topic. The next one, my topic is on transcutaneous CO2. Now, again, with these monitors, everything is possible to be centralized. And what happens is, from the transcutaneous CO2 machine, that data can be captured directly into your central monitoring station, and that data can be transferred to your discharge summary and all those things, annual report and all those things. So this is transcutaneous CO2. I'm going to talk about a little bit. Why monitoring CO2 is important? Yes, there is significant amount of evidence to say that too much CO2 is dangerous, too little CO2 is dangerous. And in the West, there are lots of litigation. If they find out that the lawyers find out that they have not managed CO2 properly, and if the child has brain damage, then the neonatologists are liable for prosecution. So CO2 has gained importance. And traditionally, what we used to use is, in the past, we used to use transcutaneous CO2 with a basic thermal device. But the heat generated by that is very significant, and that may result in tissue burns. But the current transcutaneous monitors are very trendy and sophisticated, and there are no problems with that. I will show you that one. And then came the arterial blood gas monitoring. But the problem with arterial blood gas monitoring is you cannot get a continuous measurement of CO2. You will get a snapshot of CO2, say every 4 hours, every 6 hours, but you may not know what happened in the meantime. And the third one is the end-tidal CO2, but the end-tidal CO2 cannot be successfully used in a baby who is oscillated. So, currently the gold standard seems to be the arterial CO2 monitoring for intermittent snapshots, but transcutaneous CO2 is gaining popularity. So what is the basics for the transcutaneous CO2? Basically, the carbon dioxide diffuses through the body tissue and also the skin. And it can be detected by a sensor placed at the skin surface, right? That is the basic concept. So what happens is, when you warm the skin to 41 degrees Celsius, that increases the arterial blood supply to the dermal capillaries below the sensor. And the only disadvantage is the measurement usually requires several minutes to warm the skin. And the thin layer of preterm skin has an advantage to provide reliable transcutaneous CO2. So this is how the sensor looks like, and this is the dissection of the sensor. And the components that we use in the sensor, it's Syringe CO2 sensor, which is the gold standard. So whenever you're buying a CO2 sensor, you have to ensure that it has a Syringe CO2 sensor, which has a micro pH electrode. It has an optical oximetry unit and 2 independent temperature sensors, and it automatically calibrates the sensor. So these are the 4 things that are essential in your transcutaneous CO2. And you can see in this baby, it's comfortably placed on the abdomen, the round structure here. That's the CO2 monitor that's placed, and you can see that the display of the CO2 in green. So the continuous monitoring of the CO2 by the Centec machine, which is showing a CO2 of 39.5 millimeters of mercury, and this data can be captured into the central monitor because of HL7 integration and all those things. It's easily possible to gather on a continuous basis to your central monitor. So the advantages of this transcutaneous CO2 when compared to end-tidal ET CO2, the transcutaneous CO2, it can be used even for non-ventilated neonates. Say, for example, babies on high-flow nasal cannula oxygen, babies on non-invasive modes of ventilation, they can be used, number 1. Number 2, it can be used for non-invasive ventilation. It can also be used in high-frequency ventilation, high-frequency oscillation ventilation, whether it is invasive or non-invasive. It can be used, and it can also be used during neonatal transport. Whether the baby is ventilated or not, it doesn't matter, and the readings are not influenced by ventilation perfusion mismatch. And this is better than EtCO2 in preterm babies. This was an article published by Aliwalas in the Journal of Perinatology in 2005. So these are the advantages of transcutaneous CO2. Whereas the disadvantage is it cannot be used for confirmation of the ET tube position. Say, for example, the EtCO2, we sometimes use it in the labor ward or in the theater soon after intubation to see whether the ET tube is in the trachea or in the esophagus. But because the transcutaneous CO2 takes some time to give the reading, because the skin has to be heated to measure the CO2 readings. It cannot be used in delivery room situations. It cannot be used in neonatal resuscitation, and it cannot be comfortably used when there is skin edema, poor tissue perfusion, acidosis, and all those things. There may be some alteration, but again, it's the trend which is more important than the single value. And it has to be, the sensor preparation, positioning, and all those things has to be taken care of before interpreting it carefully. And high humidity in the incubators may interfere with the readings. And another practical disadvantage is, the sensor needs to be repeatedly changed to prevent skin erythema and burns. But the modern day sensor, they use less heat than the olden day sensors, and the problems with erythema and skin burns are not that significant, right? So the accuracy of transcutaneous CO2, usually what happens is it is slightly higher than the arterial CO2. If you compare head to head transcutaneous CO2 with arterial CO2, the transcutaneous CO2 values are higher than the arterial CO2, and that is because elevated skin temperature increases the local blood and tissue CO carbon dioxide by 4.5% for each degree rise in the temperature. This is the anaerobic factor. And some epidermal cells produce local CO2, which can contribute to the capillary CO2 by 5 millimeters of mercury. This is the metabolic constant. But the modern day sensors, they have a correction algorithm applied to all these things, so that the transcutaneous CO2 is as close to the partial pressure of carbon dioxide in the arterial blood. And there are lots and lots of studies comparing different types of continuous CO2 monitoring. On the take home, this was a review article published by Hochwald et al. In Pediatrics. The take home message is the bias is very less, which is very good. When compared to when you compare one device with another device, the mean difference is very less. It is less than 5 millimeters between device, and the correlation is also good. But there is wide standard deviation amongst these devices, so you have to be slightly careful. So the current recommendation is it cannot completely replace the PaCO2, but it can be a complementary tool to monitor the trend on real-time continuous CO2, particularly in babies who are requiring high-frequency oscillation. But if you find that the CO2 values are abnormal, you need to confirm it with what you call with your partial pressure of with the arterial blood gas and partial pressure of CO2. But generally, the trend is good enough. And currently at SKS, Centec transcutaneous CO2 is we are being a part of the Centec team now, and we will provide Indian data during my next talk. Salem data I can provide on transcutaneous CO2. So this is all about transcutaneous CO2. On the last bit of my talk, quickly I will browse through the transillumination. So transillumination or cold lamp, what is it? Probably many of you would have used this. I'm going to show you different devices and the evidence behind that. Now, I personally, I have used transillumination since I was a trainee in London since 1998-99. And I personally feel that it is my third eye, because my normal two eyes, that's fine enough. But without the transcutaneous devices, my success rate in IV cannulation, the peripheral PICC line insertion, they all comes down significantly. And with the transillumination device, my success is very good. So this is, that's why I call it as a third eye. So it can be used to localize an artery or vein for cannulation or blood sampling. It can be used for bladder aspiration. Transillumination verifies the presence of urine in the bladder and shows the size and the location of the bladder. Yes, but there are some pitfalls with that as well. But generally, yes. and cannulation of the umbilical vessels. If you transsimulate, you can see the path of the vessel, and you can say whether it's in a false passage or an umbilical artery or a vein. And then it can help in transillumination for pneumothorax and also intestinal perforation. So these are the various uses of a transilluminator. Now, I will show you how it works. So this is an adult finger, and obviously you cannot see any vein in this area, right? This is just for demonstration purpose. But if you look at, if I put the transillumination device, right? So you can see that the veins are beautifully visible, right? Okay, so that is, and also in this baby, the pneumothorax, the chest, you normally, when you transilluminate the chest, you will see only a small halo around the light, which is normal. But in this baby, you can see that the whole chest is transilluminated, showing that there is a left pneumothorax. And in the second baby on the right here, you can see that the abdomen is brilliantly getting transilluminated, suggesting that there may be a perforation in this area. So these are some benefits of transillumination. Now, what happens is traditionally we use the cold lamp. Again, this we were using it in the UK. So what happens is there is a box and there will be a light source there, and there will be a fan there. And this light source will provide very bright light, and this bright light will travel through this tube, which is placed at the baby end. And because the light source is far away from the baby end, it doesn't get heated, and hence it was called as a cold lamp. Now with modern day LED technology, this particular machine is getting outdated. And in the past, when I first landed in India, this traditional cold lamp used to cost around 70,000 rupees. This was in 2010. And now I guess that the price has come down to 11,000 rupees approximately. But someone in the panel, or Dr. Prashant Gowda or Dr. Dinakar sir may correct me if I'm wrong, but this is the latest information that I could get. The second thing is LED lamps. Nowadays, you get LED lamps for 800 rupees. And simple lights like this does the purpose, right? It's bright enough, and for neonatal veins, you can easily see. And some clinicians have used otoscopes, and even there is a study published in 2004 where they have used otoscopes, and they found that 39 out of 40 patients, they were successful in getting the visualizing the vein and cannulating accurately. And but there are special devices. The problem with these devices are it may be difficult to clean because the light source is slightly bit deeper, and the risk of infection is there. And also they're all not medically manufactured, so there is still a possibility of burn if you use it for a longer period on the skin, and they're not FDA approved and all those things. But it is cheaper in the developing countries. Whereas the proper one, which is approved by the FDA and all those things, safety, medical devices, these devices are expensive. And one of these special devices called Vein Light, which there is a pediatric version and a neonatal version of it, and they cost around $349 for the neonatal version. And it has benefits. It has multiple different colored lights. There is an orange light and a red light. Each light one is good for veins and another one is good for arteries. So you can select which one you want to cannulate. Right? And there are other devices like V-Sight. This is also this is easy to clean, and it's easy to be placed on the baby's hand when you're cannulating. But this one also costs around $107. But it's still cheaper than the previously 70,000 rupees proper cold lamps. And now, all this time I was talking about the transilluminator. So transilluminator is the one which you can look for veins, for perforation, for pneumothorax, for cysts, and definitely it is better than naked eye. Whereas there is something called as an infrared vein viewer. This can be used only for viewing veins, and there are research to say that it's better than transilluminator in detecting the veins. I will show you how an infrared vein viewer looks like. So this is AccuVein, AV400. This is a vein viewing system. And this child is an 8-month-old child. So basically, you just shine the light on the back of the hand or on the leg, and you see the veins very easily. And this is an infrared technology, which is used in a slightly different way. And what is the evidence on these transilluminators? There is a study by Russell et al. Published in 2018. Now, they looked at the low-cost bicycle lights that are available even for about $2, $3. And they compared the study, and they found out that with no light, majority of the veins were invisible. And with the cold light, veins are visible, easily visible. But with the bike light, even more number of veins were visible, right? So the odds ratio, they compared the skin color, the light, the light type, basically the cold light versus no light. The odds of detecting the vein was 12.5 times, and the bike light was 34 times, and the bike light versus cold light was about 2.7 times, all with a significant p-value. So they concluded that the bike light, the cheaper bike light is more, the bicycle lights are better. That can be used in resource poor countries, which are cheaper and easy to clean and all those things, right? And there is another group which published a randomized control trial comparing the transilluminator versus the infrared device. So they divided the group into 90 babies into 3 groups, neonates. So infrared group 30, transilluminator group 30, and the control group 30. And then they found out that, and they used the AccuVein AV400, which is the infrared group, versus the V-Sight transilluminator. These are all medically endorsed devices. And they found out that the time for successful cannulation was better with the infrared group. It was very quicker when compared to the transilluminator group. And success in first attempt was better in the infrared group and the transilluminator group when compared to the control. And the duration of the time the cannula lies in situ is significantly higher than the transilluminator and the control group in the infrared group. And the neonatal pain score was also significantly better in the infrared group. So they recommend that the infrared vein viewers are better than the transilluminator, and the transilluminators are better than the naked eye. So what to focus now? So we have to make sure that we have an infrared device and a transilluminator device so that it serves both the purpose. You get a good view of the vein, and also you can look at the pneumothorax and perforation and all those things. But at the same time, we have to ensure that it's a proper medical device if you can afford. If you cannot afford, you can go for the bike lights or cheaper LED lights. But you have to make sure that the heat source does not cause excess heat to the baby, and you should be able to easily clean to minimize the infections. And I think with that, I'm finishing my talk. Thank you very much for the organizers for giving me this opportunity. I'm happy to take any questions.
Thank you, Ram. Wonderful presentation.
Thank you, sir. Thank you.
And very, very clearly, you showed how technology can ease out the job in terms of documentation, in terms of space management in the hospital, MRD management, plus how technology can reduce the medical errors and how simple it is. But only thing is the installation and use of technology, which is a high time now to do it. So before we take up questions, now we have 3 panelists for today. Dr. Suresh and Mr. Murugan and Dr. Kishore Kumar sir. So I'll start with Mr. Murugan, his views and his inputs on today's topic, and then followed by Dr. Suresh and then Dr. Kishore Kumar sir. Over to you, Mr. Murugan.
Yeah, thank you very much.
Just 1 second. Sorry to interrupt. Ram, you're still sharing your screen. We are seeing your shared screen in a loop. So can you stop sharing your screen?
Yeah, sure. 1 second. Stop sharing. Yeah.
Sorry, Murugan, please go ahead.
No problem.
Yeah.
Thanks. So here I have a question here, probably on the clinical side, which I need to check on TCPO2 and TCO2 when we all are using. Definitely there is a heat which is produced and it irritates the skin of the baby. How often do we need to change the site?
That's a good question, sir. The previous sensors, that we used to use in the UK, that used to generate a heat of about 41 degrees Celsius. But the modern day sensors, they generate only around 37, 38 degrees Celsius to heat the skin. Roughly in the past, we used to, every 4 hours, the nurses used to check and change. But with the modern day sensor, it's not required that frequently. However, it's better to follow the instructor. Each baby, it is different. For a very preterm baby, say for a 500 gram baby, 600 gram baby, we may have to change a bit more frequently. And whereas for a 1.5 kg baby or a term baby, the skin is very strong. So it varies with baby to baby. And currently there are no randomized control trials to say, or trials to say what is the best way, how frequently should we change and all those things. I think it is individual, still 3 to 4 hours. It's similar to changing a saturation site. It's better to keep a close eye on that and make sure that it doesn't burn the skin. But the chances of burns are significantly coming down with the modern devices.
Okay, thank you, doctor. It was brilliant the way you showed practically how a neonatal ICU is operating, and we could see various equipment, and Dr. Suresh's point of cluttering the ICU with power cords, how you have eliminated those with so many equipment around the baby. It was a beautiful presentation which you did, and practically we could visualize how the ICU looks like. It was brilliant.
Thank you, sir. Thank you very much.
And one more point, I don't know, from the industry point of view, I just want to ask all the clinicians in the forum here. We have 2 sets of things. Okay, one is the clinical decision support, which is predominantly being promoted by the industry, which is your ST mapping or balance of anesthesia or your hemocyte, the data, the trend data and things like that, which is practically we are using AI technology and all that for day-to-day usage. On the other side of it, we are talking about the data storage and utilizing the data for records. How do we hierarchically look at it? Which is more important? If it is both, then how do we prioritize buying it? Anybody, including Dr. Suresh, can, because...
What was the question?
Sorry?
What was the question? I thought you commented something.
You are CDS versus what is the other half? We lost you.
See, okay. Basically, we are talking about 2 things. One is the clinical decision support. There are lots of tools, balance of anesthesia or hemocyte or ST mapping. There are sepsis management, sepsis, a lot of things. A lot of these tools are developed on the patient monitoring side. On the other side, all those data being interpreted and interpreted as data storage and utilized for the future usage. If given a chance, where is your importance will be? To the clinical decision support or to the data management side? Both are important. Very clearly we know. But there are 2 sides of it. Like everything, there's no free meal as such. Yeah.
It's a very good question. But before I answer that, I want to congratulate all the 3 speakers for the wonderful lecture this evening. To answer to your question, I think it's totally separate. It's like apples and oranges. Data interpretation is immediate clinical management is what helps. But the other one which you are asking is helps more in research to improve the performance in the future, or publication of papers, collection of data. So both are useful in one way. One is for immediate, the other one is publication and future learning and various things. So in other words, both have its own role. I hope I answered your question.
Yeah, pretty much. But if the hospital, when it comes to the purchase and affordability and all, where does the importance goes?
Well, when the hospital comes into purchase, unless it's managed by a doctor like Suresh or me, they will look at ROI. So they won't be interested in publication and research and future. They want it today. So it depends on who is managing the hospital.
True. Most of them are looking at the short term and what is the immediate benefit. There are two things that typical hospital management looks at is if A, it's going to improve patient care, how do I benefit from it? Is it something we can charge more, or is it something that we can use to market ourselves as better? Sometimes even if you're not charging more, you want to promote as having providing better care. But both need not be mutually exclusive, because the CDS is going to help you in the now, but the data which you're collecting will help you with, like Dr. Kishore said, publications. And with the advent of cheap storage, first of all, because nowadays storage, I mean, people who had laptops for more than a decade, remember how, I mean, storage, we used to measure storage in terms of megabytes. Now we're talking about gigabytes and terabytes. A laptop comes with 1 terabyte of data, which was unimaginable. But that also means that we can store large volumes of data. With what you've seen with Dr. Ram has done, data, actually there's a lot of data being generated every second. The syringe pump, for example, generates data, I think, every 10 seconds. The monitors are generating every second, etc. And once we have a large cohort of data, part A is being able to store it, and cheap storage allows it. Part B is number crunching. And that's what, often you see the buzz calling big data. And big data is nothing but you have large volumes of large data sets, large volume of data, and you have the CPU power to process it. And the machine starts showing trends. And then comes what's the current buzzword, AI and machine learning. So based on this, you can start predicting what are outcomes, what to be prepared for. And one of the things that Dr. Ram uses is something called the hero score, which is similar trial. They used a lot of data, and based on the hero score, all that they take is the heart rate from the baby. It works only on babies right now, neonatals. They just take the heart rate, and with 3 hours of data, it doesn't come out immediately. Once you've connected the baby, it takes about 3 hours. And with 3 hours of heart rate data, they use heart rate variability, predict something called a hero score. And in our experience, it's been remarkably accurate as a predictor of not only the possibility of the baby getting future infections, but also a lot of other anomalies. And Dr. Ram can, as the clinician, tell you what it's doing. But there is a definite benefit in being able to store and analyze data.
Okay, got it.
So Murugan, just to answer your question, there is a lot of case studies available. In fact, New York City group of hospitals was managed before by MBA guys. Subsequently, it was taken over by a physician who became the CEO. And he invested heavily in the equipment which gave data and research and publications facility. In the short term, he was criticized heavily because he was investing in a lot of things. But 5 years down the line, that group of hospitals had 200% increase in publications and change of management. It affected the care and also the outcomes of the patients because they had a lot of research and data. But it all comes down to the size of the hospitals. What is the fund available? Who is managing the hospital? In general, the experience from the US shows that any hospital managed by a doctor is much well oriented to research and data collection and change of management in the future. Any management held by just administrators with no medical knowledge is always interested in short-term ROI and outcomes. That's why there is a push in the US for all the hospitals to be managed by the doctors nowadays. So in a sense, I think I've answered your question, but it all comes down to whether Suresh is managing or somebody else is managing the hospital and the funds available and the size of the hospital.
Yeah, in that case, Dr. Suresh has got both. So He's not just a manager by accident, not just an MBA. So he's a clinician as well. So he can justify things much better.
Well, think you're too kind, but I think there are a lot of people who have questions. Let's see. Ask the crowd.
Yeah, I think the few couple of questions which have come, that is cost of transcutaneous monitor and traditional cold light not able to procure in Bangalore. Any needs or suggestion, advice or contact?
Sorry. I didn't understand. What's the question?
It's in the chat. Cost of transcutaneous monitor. Does it need to be changed every 4 hours? That is skin position, which you have already answered.
They're asking the cost.
The cost of the monitor it's a bit pricey. It's about 15 lakhs. And it's not just the investment in the monitor, but the probe that is used has a life of about 18 months. They do say that with care, it can go up to 24 months. And the probe costs about 1.5 lakhs, if I'm not mistaken. But when you compare it with the cost of repeated ABG, blood gas tests, and especially neonates, where I remember Dr. Ram, saying every drop of blood is precious for my baby. So the baby might not just have enough blood for you to do multiple blood gas analysis. So when you compare the both, it actually is a good investment.
There is
they
one
asked
more
about
question.
The cost of the cold light.
Yeah, traditional cold light not able to procure in Bangalore. Any leads?
I think Dr. Kishore or Dr. Prashant can give a better idea.
See, it may not be procurable in Bangalore, but there are agents and distributors available, and that's where I think Genworks is making a huge difference. That one-stop shop. I'm not supporting Genworks because they're sponsoring this lecture, but a lot of the major equipments we used to get from good companies. These are all what we call as a minor allied equipments, and there are no single or what do you call proper dealership. And even if there is dealership, the distributors change constantly. I can tell you from the experience of Cloud9 15 years ago when we started, the major problem for us was infusion pumps. Because we were used to using Teremo in the West, and suddenly you come here and we had a lot of problems with the infusion pumps. To set the rate at 10 ml per hour, and there was no consistency. Suddenly there would have gone 100 ml per hour, and then they used to say calibration error, which we wouldn't have known. It was biomedical engineers would have told you a week later that this was the problem. So a lot of these issues, both in infusion pumps and syringe pumps, was leading these equipments to sort of rot in the shelves, needed to be fixed, and there are not many dealers at that time. I think in the last 5-10 years, if I may say, there are a lot more choices, a lot more quality control for these things, and much more robust machines available. Before that, the cost difference between the imported equipment and the Indian equipment was huge. And many times, because it was considered as a non-essential equipment, you'll end up buying either Chinese or Indian, and then you suffer, and then you realize that you shouldn't have paid for this. So it is a matter of getting a decent standardized equipment, even if it is a non-essential equipment, because many a times you compromise on the cost. You buy good equipment for the major ones like incubators, warmers, ultrasound machines, but the small ones, when you try to save the cost, get burnt easily. You need to make sure that these are the ones which are more critical and much more gives you much more headache. I'm sure Suresh coach for that.
True. I mean, I 100% agree, because even if you wanted to get some of these equipment, especially like you said, neonatals, margin of error is much less, and they were just not available. Or there'd be one distributor who would charge an exorbitant price because only 5 people in India were buying it, and he had to import it specially for you. So from that, today it's been a market improvement, and almost everything. Even if you're not able to find a local distributor now, I think on an internet, India Mart, Amazon, even Amazon and India Mart are selling medical equipment. So there's a lot available online.
Yeah, just to add to what Dr. Kishore said, one of the things that we are trying to do is to bring transparency and also make sure that we have economies of scale when we negotiate. So we are trying to bring in most of the NICU newborn care right from consumables to whatever you think as important equipment. We have taken some 34 items which we have taken from experts, and we are trying to bring it in. And most likely in a few weeks from now, we should be able. We are launching it in our e-store. And this is not for this is only for our customers. We're not wanting to do it for. We don't want to be the Flipkart or Amazon. We just want to be a store where our customers can dive in, and also we have plans to make sure that instead of you stocking it up, we stock it for you. We become your storage, and you just take it when you need. When we have your consumption pattern, we can keep that on your basis, on your PO, and you can take it whenever you need. Maybe in we are working on a lot of things. Maybe in 2 to 4 weeks, we should be launching that. We already launched our e-store. We're just doing a lot of testing around it to make user convenience, because that's the fundamental thing in anything that you do in e-commerce. We'll come back to you on that. Very clearly, we believe that being in the NBC newborn care space, we can't just be selling ventilators and brain monitors and criticals and hypothermia machines. We have to be holistically present if you are a solutions company. The first care area we are really focusing on completing the scope of supply is newborn care, which includes a lot of AI solutions as well.
Yeah, thank you, Ganesh. There is one question which has come. How to decide on choosing the monitors? They've specifically asked that Missimo says it can pick up saturation in 7 seconds. Then the GE monitors, they have certain, they should market with certain advantage. Mindray comes with cost and other features. In terms of accuracy, in terms of what is the relevance of FDA approval on the equipment or CE approval on the equipment? A few of the Korean does not have FDA, but they have CE approval. How to decide basically on choosing things? Because a lot of confusion is created when each and every company person comes. How to choose on that? I will throw this question to Murugan.
Fundamentally, see, if you look at a patient monitor, there is no difference between whether it is Philips or GE or Mindray or anything, because it's for ECG, NIVP, SpO2, temperature, respiration, those basic parameters. Where the difference is made is two things. One is how well the customer service can be provided. What will be the life cycle cost? How will you be able to manage the life cycle cost in a convenient manner so that the return on investment for the hospital is made in a successful manner? Spares availability in India, say, except the plastic parts, say 90% of the parts available in India. Then, of course, the capital cost. So these are the prime things which you look at it. Fundamentally, on the technical front, on a comparison, most of the monitors are 90-10 the same.
Okay, Kishore sir.
Yeah, I think Murugan touched upon a good point. Most of the monitors are fundamentally same, but the significant point here is it's always better to take a reference of which hospital is using and what is their running costs, because ultimately AMC and CMC will determine what you are paying, and the cost of the probes, especially with the monitors, you have to use the probes for saturation and temperature, and that's where the cost can vary when running costs over a period of time. For example, we have used GE monitors, and for the last 15 years, we haven't had any major repairs and major breakdowns. But subsequently, we had procured 1 or 2 other monitors. And what happens is when you try to procure the probes sometimes people will say that is expensive, you buy this is cheaper, and this, that. So all this come down to ultimately the cost of running that equipment and how accurate it is and recording and various things. So it's always better to go for either a FDA approved or some other good company, because these are the companies which you don't want to have trouble with. I mean, monitors, because one monitor is out of action for a few months and you don't get a service to be repaired, then you have to have a spare monitor, and when you have the need, and that is where the things come in. The other thing is, there are some companies which show you actually they drop the monitor from a height of 5 feet, 6 feet to show that it's unbreakable. That is also equally important, because sometimes what happens is, accidentally people drop and the screen breaks, and the screen repair can be quite expensive. So at the end of the day, I think it's better to talk to people who have been using what monitors and how their experience has been, and then decide. And that's where I think choosing becomes much more important.
Dr. Suresh.
Yeah, thank you. Two things. One is most companies will give you a demo which will allow you to hold on to the monitor for several days, that you can actually develop a personal comfort. So before buying or deciding on any monitor, please ask for a demo that you can use it with your patients. If you're running hospital, obviously, if you're starting a new hospital, you don't have you're in the initial procurement, you don't have admissions yet. It might not be feasible, but do try to test out all the monitors and see what you're comfortable with. There's also an advantage of deciding on one company and sticking with that company, because you get the advantages of a platform. Most companies have a range of monitors, and if you stick to one company, you can interchange both the central monitoring system works with different monitors, because not all patients need high-end monitors. So you can actually use a lower-end monitor. But if you mix and match between different companies, the single central monitor will not work typically with two different monitors. Whereas within a single platform or company, it's easier to mix and match. And coming to probes, almost every monitor company offers Massimo and Nelcor as an option apart from their own proprietary version. So sometimes it makes sense to go with, say, Nelcor or Massimo, because there are certain advantages with those probes and easy availability if you're going for a lesser known monitor. The bigger monitors, I mean, Philips, GE, Mindray, they're all well established in the market. So even if you go with their own probes, there is easy support and easy availability of the probes. So you need not worry about that.
Yeah, as you very clearly said, low acuity, mid acuity, and very high acuity. So we have various ranges. It's big bouquet of flowers with different flowers. You pick and choose different monitors. The accessory compatibility between the ranges is very critical, and that is going to make or break it. Because if you really need to maintain 3 different inventories for low, mid, and high, then it becomes a very cumbersome process. So accessory compatibility, central station alignment, whether that full range can get into a single central station, the ease of use, the user interface, whether it is low, mid, and high, is it the same user interface? The staff nurses does not need much of training. Those are fundamental things which we need to really see. If you're really looking at some kind of like, say, ICG kind of things where non-invasive cardiac output or RSO2 kind of parameters, then you need to look into the specialty where which company has got it and which is integrated mainly with the main monitor. Those kind of things need to be looked at. For basic monitoring, the choices are plenty. It is more the choice of customers. Yeah. Thanks.
Yes, Dr. Suresh.
There are some questions regarding the Transcutaneous CO2. I see that Dr. Tripti Chatji, she is one of the distributors for Centec. She's also online. So, Tripti, if you can weigh in on TCO2, it would be nice. I'd invited her and I can see she's available. Centec monitor, Centec makes is one of the 2 manufacturers of transcutaneous CO2. Radiometer is the other one, and we've got Centec. That's why I invite. Otherwise, we'll just continue, and if she joins later, we can.
Yeah. Dr. Sushanth, your inputs on this.
Yeah, so can you hear me? So I think monitoring, one is there has been some change. A, in terms of people who are now in the market. B, in terms of the options that people are providing. Uh, and it's a very individual institutional decision at the end of the day what you want to do. Like somebody pointed out, basic monitoring, there are a lot of options, but you don't stop at basic monitoring because you also want to future proof. These are machines that are going to stay with you for 8 to 10 years minimum. You're not going to refresh them every year or every 2 years also for that matter. So I think that's where quality becomes important, because running costs and future proofing both are important. So let's say I want to start an ICU today, but tomorrow I want to connect it to a hub somewhere else, or I want to digitize it later on. Then it becomes important that you have those digital options available. Similarly, when it comes to quality, some of the larger companies uh, have it future proof to some extent, so it's easier to kind of upgrade it at a later point. The other thing is it keeps evolving. Some of these technologies keep evolving. So the other thing that you have to keep in mind is whether the modularity that is available within the monitors is something that can be taken care of in the long run. So I'm able to use the same monitors as basic parameters also, but if I need to add some more parameters into the same monitor, it becomes easier to just buy a module than buy a whole new monitor. So all those things need to be considered. Having said that, I think quality becomes important just because these monitors are going to stay with you for a longer time. And so is the service provider. You can't have a company which sells your monitor at a cheaper cost, but then kind of is not really up for service, because somebody will always do it for cheap, right? You have seen that Mona Lisa painting, like somebody has made it with a crayon and there is an actual painting. Somebody will always be there to do it for cheap, but at the end of the day, you have to look at future proofing and your running costs as well.
Dr. Suresh and then Dr. Ram.
Yeah. No, I think Dr. Ram can go ahead. Ram, please go ahead.
Okay. I'll just share my screen to show the cost analysis of. There are studies in the US where they have done the cost analysis of the EMR and the hospital management system. And what they've done is, so on the x-axis is the years, 2006 to 2013. And the darker bar is the EMR system and the whiter bar is the paper chart system. And you can clearly see that in the initial period, the EMR system is in negative balance. But after a few years, the EMR system starts to make positive returns, whereas the paper charts are drained, because the longer you store, particularly in the US or in the UK, you need to store them paper medical records for 21 years. And the cost of that tremendously increases. And so they've concluded that positive cash flow from EMR is around 6 to 8 years from implementation. The benefit cost ratio was 1.23. Probably Kishore sir will understand this better than me. Discounted payback period 6.18 years, and the net present value of this this particular hospital, $3,617 in thousands. $3,600,000. It's a positive balance that they showed. And there are other studies as well, Wang et al., Barlow et al., and Hillstead. They found out that there is significantly positive financial ROI, improvement in revenue, and 81 billion annual savings after the initial 6 to 7 years of implementation. And not only that, MRD, medical records department, manpower costs, medical secretaries costs, that rate reduces significantly. And the medico-legal costs, litigation costs are significantly reduced when the quality of care is improved. These are all unaccounted costs, but definitely this will be of great use. Somebody asked this question on cost of the EMR. That's why I thought I'll show these slides.
All right. I think if any of our delegates have Any question they can unmute and ask. Dinakar sir.
Prashant.
Yes, sir.
Yeah. Suresh, as usual, no need to tell about RAM. Really, in a quick time, you have done a great job collecting the transcutaneous things and transcutaneous CO2 and what is the things? So EMR regarding the syringe pump and the infusion pump. Just I thought I will enlighten the knowledge about 4 things here and one question for everybody. I think so, Suresh and Ram, you might have gone to everywhere for the exhibition. That time you might have seen only around 90 grams to 120 grams syringe pump, and around 225 grams is the infusion pump. So that will be costing around Indian rupee around 70 to 75 Indian rupee, and up to 2 kilo what we use at present, any company at present in India is available 1.8 to 2. That's the minimum syringe pump weight. The weight, suppose, and the bulkiness. So just now Murugan was telling there was so much instruments, instruments, and that syringe pump docking system is covering almost that. Suppose if you put the infusion pump, that itself you cannot go almost 4 feet that side, this side. So it will occupy almost 1.5 feet to 2 feet that side. If you'll syringe pump, infusion pump, once again it will occupy so almost 3.5 feet, then wire gear and all. So what about the thing 120 grams syringe pump? What is transportation? Number 1, as well as the in the NICU, very minimal. Instead of 2 syringe pump place, you can put it around 4 or 5 syringe pumps and infusion pumps too. This is number 1. Cost is expensive. You know that American company, it is very expensive, but it is, you can know it's a, I'll give you all the company things. It is also can be connected to the central nursing station as well as even HL, hospital direct connection is also there. And what about the thing? There is an infusion pump for subcutaneous, continuous, even peritoneal. There is a continuous, this thing is also there. And what about feeding? Regarding the feeding itself, syringe pumps have come or infusion pumps have come. Any knowledge or please give the your experience about that, because we can use it in the adult ICU, we can use it in the neonatal ICU about for the feeding syringe pump or infusion pump and the pipes. That is one question to me about the syringe pump. Then the second thing is regarding the monitor. Actually, Sushanth was telling better to go with the basic only, but higher end machine, because anytime you might need an upgradation. Very good. Because some companies do have, example, BPL, they are buying, I don't know from where they are buying, but they have incorporated the things. They are having SpO2. If the SpO2 monitor, it comes down, it will have the apnea monitor. It will only shake the leg of the baby with a vibration. If it comes more than 3 times, according to the definition, it will give a exact alarm baby is going for repeated apnea. So that is the thing. Suppose if anybody wants to go for a neonatal, that one. And touchscreen monitors have come in almost all the monitors have a touch screen. And monitors, even with the touch screen, with I think so, Massimo is 7 seconds. If it is, and there are so many other machines also showing in 4 seconds. And accuracy, and many monitors are having, what is that, calculations. Just enter the weight and how much this thing. And in your thing, dobutamine contains 1 ml contains 50 milligram. Dopamine, 1 ml contains 40 milligram. Milrenan, how many microgram per ml? Then give the calculation. If you'll put the calculation, many monitors itself will tell you, please take this much ml, this much ml, this much ml. Even respiratory calculations itself, it will show. All the things are there in the monitors itself nowadays. Only thing, we will tell our nurses, put the SpO2, put the, and I think so Suresh told he is going to take some Suntech people. There is in Suntech, NIBP is there. Suresh should take her in the line, then she will guide us. Because in Suntech NIBP, we have to give 30,000 extra only for neonatal, pediatric or adult BP. Because their system is not like whatever oscillatory method, what all the machines are giving BP in an oscillatory method. Their one is not exactly oscillatory method, but more accurate. During the inflation itself, it will give what is it. And oscillatory during the not inflation means when the air is going out, that time it will, this thing, BP will get, that is a oscillatory. Suntech is using other method. It is more accurate for a neonate. So if anybody is buying a new monitor, please ask whether you are having Suntech NIBP. It is more accurate. Regarding the TCO2, I think so she is going to tell us, and Ram and Suresh might have done a great this thing. That Delhi person, what he was telling, with liquid or with gas, without gas, or all those things that you, from 15 lakhs, it has come down to 9 lakhs. Now, previously for 4 lakhs we used to buy. Now I think so 8 to 5 lakhs something. I think so she is going to tell us Suntech, because in Suntech there are two things will come, everything he might have done it. So she will tell you. Then my question answer, somebody can answer me about the, what is it, a feeding syringe or infusion pump.
Okay. Dinagar, as usual, a whole bombardment of questions. Ram, I think you're still sharing your screen. You might want to stop sharing. First of all, I just spoke to the Centec representative. She had to quit because of family function, so she sends her regrets. Maybe we can get her on for a different program. And now I had to think about, Dinagar asked some 4 questions. Syringe pumps. Yes, some of the newer generation syringe pumps are coming that are much more compact. I know Mindray has got a new N series that I've seen, which are like probably half the size of the previous syringe pump. I'm not sure about the weight. The syringe and infusion pumps are really compact. But other than if you're using for transport, is there really any advantage? Are you sacrificing anything and paying extra for a lighter weight syringe pump that you're not going to take advantage of? It's not like you're putting the syringe pump on top of the baby. It's going to be on a dock. And yes, transport, moving it from one way, I mean, for the staff nurses, it might be easier. But again, comes analysis between cost versus benefit analysis on that. That is my first answer to one of your questions. Centec, unfortunately, she's not available. Then what was the other thing? Sorry.
Feeding, for the pediatric ICU or NICU or the adult ICU, morely pediatric and adult ICU, they are using, infusion pump for the feeding and syringe. This thing regarding that.
I've heard and seen of the systems. We still haven't implemented it, so I don't have anything to add on that. And what was the 4th question then?
Regarding the monitors, there are so many monitors. So touch screen will come, but over 1.5 years to 2 years, because if you will keep near the monitor warmer, usually touch screen will have something filament that will freeze or melt, or it will become dry. Touch screen, the method. Okay. So what is your experience about the touch screen?
Okay, when it comes to touch screen monitors, I mean, there are advantages. Probably our other speaker, Sudhakar, I think he might be able to add some valuable information, and Murugan is also there. But yes, the advantage of regular knobs is tactile and what's called as muscle memory, as in it's easier just to touch and do it. But then it's just like when the iPhone came and the entire, from BlackBerry to iPhone, you had the option of flexibility on the screen. So with the touch screen, you have a flexible user interface that can be adapted. With new software updates, you get new features. The other thing with touchscreen is maintenance. Sterility is much easier when you clean, it's a flat slab that you can clean, other than knobs, which all become points of possible infection. In our experience, we've not had any issues in the NICU keeping monitors next to the NICU, next to the warmers. So we've not had any problems with that.
Here, I would like to add a point, Doc. So the touch screen, the old generation touch screen used to be resistive touches. where you need to physically touch it so that the point gets grounded. But today the touch is all pretty much a capacitive touch, where almost close to the screen it starts working. We are not giving any kind of a physical pressure onto the screen. So the technology itself is like leaps and bounds have grown. So the problems what we had a decade back, 8-10 years back on the resistive touch is not the case anymore. And you don't have to have any kind of a second thought, as long as the touch screen has got a gesture control and things like that, where life becomes so easy. There is no problem as such, and it's pretty much a proven technology, Doc. So,
in fact, like Murugan said, that it's able to detect your hands even before you touch it. So future will be gesture control, where you just wave it, and in terms of sterility, without even touching the screen, you can make changes. And you also mentioned about BPL. BPL, I believe, gets the monitors one range from Komen, and Komen has that feature for apnea monitoring, wherein they've got a probe that you put to the baby's foot, and it gives like a tap on the foot if the saturation level comes down. So that is what Dr. Kinagar was talking about. It's available it's available actually from Komen. Anyone else?
Because they have taken from that this thing, no? What is that? There is one company, Miracle. I don't know what is that company. If SpO2 comes down, apnea, it will blink, and temperature for the this thing that they are putting for the babies for hypothermia. They are also having the technology has been taken from them. So why I asked you is syringe pump, infusion pump. Is there any criteria to take this syringe pump is better? Because syringe pumps is available from, even if you will see it, we are using Hawkmate 400 or Hawkmate 400,000 since almost 14 years. When we are doing every year calibration, 0.2 ml only the difference, because the 0.2 ml is evaporates for 24 hours. 18,000 since 10 years, it's 9 years it's working. And what if suppose if it is 18,000, there are other syringe pumps that what is that thermal or something, what Dr. Kishore was telling. Even we used to use that first, but it is more rugged and more this thing. Battery backup here is also there. Why that cost is so expensive there?
So, Dinakar, see, for example, if you look at baby weighing scales, the baby weighing scales you can buy anywhere from 200 rupees to 20,000 rupees. All comes down to the accuracy. If you want to weigh the baby, with the error of plus or minus 10 grams, the cost is going to be higher. If the error is plus or minus 200 grams, then the cost is going to be lower. So it's the accuracy of running the syringe pump or infusion pump. I think in neonates, the accuracy is very, very important. So what you need to do is ask for the proof of the accuracy. Because if you set the infusion pump at 0.01 ml per hour of dopamine, it should deliver 0.01 ml and not 0.1 ml. Because as a clinician, you will not know whether it is delivering that much or this much until your syringe has run out. And many a times you see the clinical response and then you say, what happened here? And the nurse won't know, and then you won't know, and suddenly the baby's blood pressure is running nicely because instead of 0.01, it may be giving 0.03. So the accuracy is at most important in a syringe pump. Second thing is the serviceability. How good their service, because see, in India, the main problem is you buy a lot of these things through distributors. The distributor who comes today is not going to be there tomorrow. Then they will say, well, we don't know who the distributor last year, this is my distributor, I'll try to do the best what you can do. So in these sort of things, that's why it's always better to go a standard company and established distributor for the last few years, not a fly-by operator, not a fly-by company, and accuracy. Third thing is durability. You don't want to be replacing the syringe pumps every year. You want at least one syringe pump to last for at least 4 or 5 years. If it runs 4 or 5 years, you got your money back. But if you are replacing them once a year and every 6 months, then you are spending too much. That's my, I think, take-home message. Maybe Murugan and Suresh can add.
One more small point here. One, you said accuracy, serviceability, durability. The last point is the safety. How safe is your equipment when there's an occlusion, or when the syringe is near empty? How fast, how proactively it gives an alarm? Those are very important things which we really need to practically see before we decide on the pumps.
Correct.
Yeah, safety of the patient is more critical. Yeah, thanks.
We had a syringe pump which ran very nicely at 0.1. Anything less than 0.1, it wouldn't have been accurate. And suddenly, last 2 ml of the syringe, it used to give a bolus. I mean, all these are the practical problems which may not be. So you suddenly realize that the baby blood pressure has shot up because the baby has got a bolus of 2 ml or 0.2 ml. So the accuracy is very, very important.
Yeah, Dr. Prashant.
Somebody has raised the hand.
One more question.
Yeah,
Prashant,
Abid this side, sir. Yeah, sir, Abid this side. So one more thing I wanted to add from the my experience point of view. As I said in 20 years back, we used to. Can you hear me?
Yeah, Abid, just 1 second. Just 1 second. So Dinkar sir, Abid is an expert in infusion pumps, and if you allow, he can say a few things.
Please, Abid, go ahead. It is a knowledge.
So, yeah. So what I was telling, sir, last 20 years back, we used to sell. Experts are here who was using Gatsby in syringe infusion pumps or Gatsby infusion pumps. They was heavily weight, but they was very, very steady. Now, two things I am seeing when it comes to the syringe infusion pump. It is to, I just wanted to share my experience, Dr. Dinkar, on your question. One is the accessory compatibility. If accessories are available, are they compatible with all the syringe infusion pump and infusion pumps? Whether they need a calibration, are they going to be the auto calibrate? That will be the point of the discussion when it comes to the selection of the product. That is something which is very important. Second, I think I see the biggest thing on the battery backup. And third is that, ease of use, because most of the time it is going to use by our technicians, and they are, they should be in a position just to fix up the syringe or just to fix up the accessories, and it should run smoothly. And that, these 3 parameters I see, major things, and there are many players when it comes to the syringe infusion pump and the, infusion pumps. But one who has shown the accuracy, one who has shown the steadiness, one who has shown the compatibility, that makes selection of the product.
Yeah. So thank you, Abid. But one thing somebody has asked, what is the cost of what is a trans illuminator? Ram, you have done great thing doing the infrared. I think so. Just 7 years back, when it came, 7 years back, 4.5 lakh rupees was infrared for the pediatric use. That everybody knows. It was in the sampling room or in the pediatric where we will put a IV site in a procedure room. We used to place it. 4.5 to 5 lakh. Now the same infrared has come down to almost, there is in Indian, Kerala people are manufacturing. So they have brought it down to only 50 to 60,000 infrared. Kerala people, I'll give the name, and come to the LED light, cold light, near next to your Coimbatore, that place, they are, trans illuminator, Sriwell company or Sarwell company, they are giving it for 15,000 rupees. Only problem is that card, what they are giving is 6,000. Other around another 10,000 is that instrument where light throws in the 2 lights. Then come to the neonates, whatever it is there, even from 15 rupees, 45 rupees to 400 rupees, there are small red, green, yellow, white. Everything will come in a single pen-like thing. According according to the whatever you want, according to the intensity, thickness, and color of the baby. Suppose if baby is dark and thick skin, or a full-term baby with a IUGR, you will be needing a different colors. That I think so. You will be knowing green color, red color, and slight yellow color and pure white. According to that, also you can use it. It is 400 rupees in all the medical. I think so. Now Corona, all our medical conferences they will sell and they will show it. It is very good, 400 rupees, and it's very good for neonates also and pediatric well. That's about the Transcutaneous. Over to Prashant.
Yes, sir. Dr. Suresh.
Yeah, I'm sorry, I've got to quit now. I've got some guests who've been waiting for me for quite some time. But before I leave, I'd like to say excellent talk. And Sushanth, I see some excellent work that you've been doing integrating equipment. And thanks for having me. I'm sorry I have to leave early today.
Yeah, I think we also have come to an end of the session now. Almost all the questions are done. So once again, thank you all our speaker and panelists. It was a wonderful session with a very good discussion, giving a clear idea about how to look forward beyond ROI, beyond how beautifully we can use the technology and make life easier, simpler,